So this is an important PowerPoint about the neurology alterations that we see in the pediatric patient. If it's too long for you, feel free to read the book instead. Same information. It's just really important information. Here are your objectives, and they're kind of long for this one. It's kind of like every time, what is it? And what's the priority of care for it, and sometimes the medication, or how is this disease different than that disease. So here's your objectives. Meningitis is an inflammation of the meninges and is the most common infectious process of the central nervous system. It can be bacterial or viral and can occur as a primary disease or as a result of complications of neurosurgery, trauma, systemic infections, or sinus or ear infections. Many organisms can cause meningitis. However, Neisseria meningitis is the most common, with Streptococcus pneumoniae as a runner-up. Until recently, Haemophilus influenza type B was the most common cause of meningitis in children older than age 1 month. But since the vaccination with HIB, there has been a drastic reduction in its incidence. The incidence of Escherichia coli and beta hemolytic strep meningitis is higher during the first 2 years of life, especially during the first month of life. The incidence is expected to decline since more infants now are immunized with the pneumococcal vaccination. So contributing factors can be any of these things. Premature rupture of fetal membranes would be the newborn or the neonate that shortly after birth shows symptoms of meningitis. It can be a head trauma, and usually that's an open head trauma. Cochlear implants is a surgical procedure. We see it usually during the winter or early spring months when a lot of viruses are going around, and it's common in crowded situations. The manifestation of meningitis, generally symptoms of bacterial meningitis, it's variable and depends on the child's age, which pathogen, and the duration of the illness before the diagnosis. All children generally will have some kind of a viral illness prior. Among infants and toddlers ages 3 months to 2 years, they could have a fever or change in feeding patterns. Sometimes we'll see some vomiting or diarrhea, bulging of the anterior fontanelle, irritability, and a high-pitched cry. In older children, we tend to see fever and irritability and lethargy, confusion and vomiting, muscle or joint pain, headache, photophobia, and nuchorigidity. So let's go back to our infants. In our infants, they say that the older infant, we can see nuchorigidity. And that's the way they kind of, I have a picture of it, actually, how they lie down with their neck extended. They generally will have this high-pitched, irritable cry and the bulging fontanelle. That's probably one of the biggest symptoms that we see in infants. And of course, a fever. With children and adolescents, all of these are, I'm sure, symptoms that, different kids get. But most common with those kids is the nuchorigidity. That's probably the number one thing, along with the fever, that we see. And the kids would generally have a positive Kernicks and Brzezinski's sign. Under 2 years old, they say it's not reliable, and we don't do it under 2 years old. This slide, the first picture is a picture of an infant, and the name of the position that this little guy's doing is ophistopatonic. Ophistopatonic. And it's where the head and the heels arch backwards in extreme hypertension. And generally, if they have meningitis, this is what it means that an older infant will show some nuchal rigidity. With the other children, 2 and above, older, we can see either a positive Kernig's and or a positive Brudzinski sign. For the Kernig's, they have the child lay supine and they flex the hip and the knee up by, we would do it as the examiner, up 90 degrees. Then we, or as the nurse, will attempt to passively straighten the leg at the knee. If the child has a positive Kernig's, the patient experiences pain along the spinal cord, and the pain limits passive extension of the knee. So they won't let you do it, and they'll complain about that this really is hurting, and when you ask where, it'll be in the spinal cord. Positive Brudzinski, once again, we have the child lay supine in an extension phase, and then we slowly grasp the patient's head in the occipital lobe region, and we try to flex the neck. Brudzinski sign occurs when flexation of the neck causes an involuntary flexion of the knee and the hip. And actually they say it's an attempt for the patient to try to lessen the stretching of the inflamed meninges. It hurts when you do that. So positive is if when you're doing the Kernig's sign, the child feels pain in their spine after you have their leg up in the air bent 90 degrees and you're pushing at the knee to push it to straighten it. Positive Brudzinski is you try to flex up their head and bend their neck, and when you're doing this, because of the pain and involuntary hip flexion and knee flexion will occur. It's the body's mechanism to provide comfort to the child. So bacterial meningitis is very serious, and it can be fatal if it's not caught early enough. It's usually caused, as I said, by strep, RNA, Neisseria, sometimes E. coli, and sometimes Haemophilus B. Viral meningitis, though, the child will present with the exact same signs, except it may be milder, compared to the bacterial. For viral, it only lasts a few days, and it actually just requires only supportive care for recovery. However, when a child comes in with the signs of meningitis, you don't know whether it's bacterial or viral, so they need to be treated as if they're both bacterial. So some tests and procedures are done immediately. The biggest test and procedure, although there's lab work and they look at the white blood cells and so forth, is the spinal tap, or you might know it as a lumbar tap. So they put a spinal tap needle in the lower vertebrae, between the lower vertebrae, and they extract CSF, and they're going to send it to the lab. But one thing that can be noted upon doing the procedure is how clear the spinal fluid is. If the spinal fluid is clear, the child probably has viral meningitis. If it's cloudy, they probably have bacterial meningitis. We can't use that as a definite thing to diagnose them with, but it really gives a little bit more information before we get the lab results back. With bacterial, the child will have elevated white cells and protein, decreased glucose, and a positive gram stain. With viral, it'll be slightly, if it's increased at all, WBCs, and normal to slightly increased protein. The glucose will be normal, and they'll have a negative gram stain. So until we know whether it's viral or bacterial meningitis, the child needs to be put in direct precaution isolation. The lighting in the room needs to be low, and the noise level should be low. These children usually have severe headaches. They're not allowed to flex their neck at all, so no pillows. The head of the bed can be raised slightly, or the child can lie in the side. Vital signs and neural signs and INOs all need to be monitored. The child needs to be monitored for pain and discomfort. And if it's a baby, their head circumference will be actually monitored frequently until antibiotics get started and sometimes some corticosteroids get started. You know, the babies will come in with a bulging fontanelle. We don't want it to get any bigger. They'll have a fluid restriction if when their spinal tap was done, it was noted that they had increased intracranial pressure. Seizure precautions need to be at the bedside, which is, sorry, she's on a roll today, suction and oxygen. And the child will be NPO, usually initially until there's an order to begin with a clear liquid diet and then advance. The families need to wear masks if they're in the room until the diagnosis is definite. But, you know, being kind and telling them everything that you're doing and what's being done for their child and what they can expect will give them reassurance. So once again, isolation, IV hydration. Many times these kids are struggling to breathe, so they'll need oxygen. And if this has gone on for a while before they came to the hospital, they'll need mechanical ventilation as well. If bacterial antibiotics, and they usually use the cephalosporins, they work the best. However, we won't know definitely for like 2 to 3 days if it's bacterial. So even the kids that are suspected to be viral will be put on antibiotics until the diagnosis is made. Antipyretics for the fever, corticosteroids to reduce the inflammation in the brain and the swelling of the meninges. Analgesics will be given, and sometimes kids will have a seizure if the symptoms have gone on for like 24 hours. So a lot of times antiepileptics are given initially. Usually it is phenobarbital. So educating the parents while they're in the hospital is probably one of the most important things you can do. You have to ensure that the child has the vaccinations that would have prevented this. So children should have a Prevnar or the pneumococcal meningitis shot or the PCV, whichever you want to call it, and the Hib at 2, 4, and 6 months, and then one more at either 12 to 15 months. And parents need to be encouraged because I'll be honest, they usually forget that 12 to 15 month one. The isolation precautions need to be explained. And upon discharge, the antibiotics and the steroids they go home on needs to be given routinely. And even though the child may fight it, and that needs to be explained to the family. One of the complications of meningitis is brain abscess. Another symptom you can look for a serious complication would be petechiae or purpura. If you see that, it generally starts at the top of the body and works its way down. This is a foot. It was probably one of the clearest pictures I could find. It's very, very serious, and you need to call the neurosurgeon immediately because this is a medical emergency, and the child is not doing well if this occurs. So Reye's syndrome is kind of rare now. We used to see it more often, but it's a pretty serious condition that causes swelling in the liver and brain. It usually occurs after a viral illness. It affects all body organs, but is mostly harmful to the liver and brain. It occurs primarily among children who are recovering from a viral infection, such as chickenpox or the flu. It generally develops a week after the onset of the viral illness, but there are some studies that show that it can occur a few days after onset. Primarily affects the liver and brain again. We don't know why. The peak time is usually January to March. In the past, it's been mistaken for other disorders. Since it follows a virus, people aren't even thinking this. The prognosis for clients is best when it's recognized early. The risk factors is that it's been associated with using aspirin, until, well, probably 30 or 40 years ago. Kids used to get that baby aspirin for everything. And certainly when they had chickenpox, parents gave them aspirin. And then a week or so after the chickenpox were improved, the child would begin vomiting profusely. And as it says here, typically follows a viral illness and it's in the winter months. So we'll see that profusely vomiting, and then in a short time, not very long, we'll start seeing irritability, lethargy, sometimes seizures, and sometimes they'll lapse into a coma. We do see prolonged clotting times as well when we have lab values in front of us. Because liver-related complications of Reye syndrome include fatty deposits, abnormal liver function tests, and poor blood clotting and bleeding that's caused by the liver failure. So these tests are ran. The children, for the liver biopsy, I wrote the procedure. I didn't know how many people have helped with a child or even an adult going for a liver biopsy. But like most procedures, they're NPO prior to the procedure. But afterwards, because it is the liver, they monitor them for hemorrhage and assess their vital signs. And if the child or adult would start bleeding where the biopsy was, you would immediately put pressure at the site and call the physician. So treatment for this child is oxygen and respiratory support. They generally will give the child some kind of osmotic diuretic like mannitol to decrease the brain edema. They'll give them some vitamin K, although today that's a little controversial whether it works to help the clotting time. There'll be a dietary consult because now we have to keep an eye on their lipids because of the fat that has been caused from the Reye syndrome, fat deposits. And unfortunately, a lot of these kids end up with some neurological deficits and they'll need OT and PT to help them along. The Reye syndrome nursing care is we keep their bed elevated just about 30 degrees and not any higher in a neutral position. We don't want to increase that intracranial pressure. We watch for seizure precautions, which is oxygen and suction at the bedside. We'll keep an eye on their neuros, their oxygen sats, their vitals, make sure they haven't lost consciousness, and bleeding precautions. We look for petechiae. These kids need to be on strict I&O, and we monitor them for pain. And once again, we reassure the client and family by telling them all we can tell them. Upon discharge, the parents need to be told to avoid any type of aspirin products. I put Pepto-Bismol here, aspirin of course, but I think even kaopectate has aspirin in it. Alka-Seltzer has aspirin in it. And so if you were the nurse taking care of this child, you would get print out a list of acceptable over-the-counter medications. Seizures is a big thing in pediatrics. It's a brief convulsion behavior caused by abnormal discharge of neurons. The result of these discharges is involuntary contraction of muscles, which is what a seizure is. When numerous nerve cells fire abnormally at the same time, a seizure results. So Here are some known causes of seizures, although there's several unknown causes. And in the neonatal period, it's probably something that you expect, like hypoxia or intracranial hemorrhage, like a stage 4 hemorrhage. Intracranial infections, congenital problems, and metabolic disorders. With children, we have to remember they can have, once they start seizures, either they go away or they can have them for life. So it could be caused from the initial neonatal seizures, or it could be from a fever, a febrile seizure. A febrile seizure is when a child's temperature goes from like 99, 98, 99 up to 101 quickly. It doesn't matter how high it goes, it matters how quickly it goes. So the child really, if they normally run like 98 and they go up to 101 really fast, they'll probably have a seizure. Other kids who maybe run 98, who just are sick and they have a fever, go to 99 and 100 and 101 and 102, they probably won't have a seizure. It's how quickly the fever rises that causes the seizure. And those seizures generally don't last long. They sometimes reoccur with another fever once or twice in that year, but generally speaking, it goes away and we don't see it anymore. It can be caused by lack of oxygen or a head trauma. Some illnesses could bring on seizures, and the majority of the seizures, I think the statistics that I read were like 8 out of 10 are idiopathic. We don't know why. So the neonate risk factors are listed on the left, and pretty much makes probably sense to you. And then for children, it's listed on the right. In most seizures, there's 3 stages. The first is an aura, and that is where the patient can tell they're going to have a seizure. Sometimes it's a smell, sometimes they'll get a tingly feeling, or they'll get like bright lights in their eyes. And they can prepare if they're a little bit older and they have a seizure disorder, they can prepare by lying down and being safe. But the aura is like a sign that the child's going to have a seizure, and only they can tell you they have an aura. The ictus means during the seizure. It's another word for stroke or attack. But in this situation, it means the child's having a physical seizure. And post-ictal means that after they have the seizur's all over, but now if they had a grand mal or a tonic-clonic seizure, they're going to have some other symptoms. They'll have numbness. Most of the time, this is lost consciousness. We see them fall asleep. They're incontinent. And they actually sleep for a long time, and when they wake up, they don't remember having the seizure. So I was writing all these different types of seizures out, and I found a nice little chart in your book, so I just made my own little chart and copied their information. So this is also found in your book. On this page, we have generalized seizures, which means the whole brain is used to have the seizure. The tonic-clonic is generally the grand mal seizure, and we see it last a little while. It can last anywhere from 30 to 50 seconds or longer. The symptoms are listed here as rhythmic, jerky movements, muscle rigidity, loss of consciousness, and incontinence. I believe it's the only seizure where we see the patient lose incontinence. So generally they'll have an aura, and they will have a post-ictal state where they sleep for a long time afterwards. Most of the time they don't remember having these seizures, unfortunately. The absent seizure, it's listed here as a brief loss of consciousness. But we see it usually between 5 and 8 years old. And usually the absent seizures will go away by the time the child reaches puberty. If they lose consciousness, it only lasts 5 to 10 seconds. And it looks like they are daydreaming or not paying attention to someone. In fact, many times teachers are calling home about these children not paying attention in school. They sometimes will drop their items that they're holding in their hand, and we'll see some other symptoms like lip smacking. Generally, they don't remember they had the incident, and they may even be confused for a minute when they first snap out of it. And the interesting thing is after they realize where they're at, they just keep resuming what they used to do. They don't lose a step with these kids. The monoclonic is what they call a variety of seizure episodes. They can have symmetric or asymmetric involvement. Brief contractions of muscle groups or just of a muscle. There's no postictal state. It can involve their face, their trunk, or their extremities. And they may or may not lose consciousness. But we think of myoclonic as really a brief, isolated, jerky movements. And it doesn't last long. It goes away as quickly as it came, and there's no postictal state. The clonic seizures are right here. Once again, they are repetitive, jerky movements. That's all they are. Tonic means muscle rigidity. That's when they, arch their back and stretch out. And then atonic is loss of muscle tone. These are all controlled by the entire brain. Then we have the small part of the brain, and they're called partial seizures. The focal seizures are interesting. There's no loss of consciousness. They're motor symptoms, sensory symptoms, and it can be psychological symptoms as well. The complex partial, the patient's consciousness is altered, but he doesn't, lose consciousness. So it's altered, so he may actually forget where he's at for a couple minutes, and just, even though he's awake, drift into another world. These are children that have the lip smacking or the repetitive and involuntary movements. This child may get up and walk around, act restless, and he just doesn't know where he's at. Similar to a child that's sleepwalking. And then the partial secondary generalization. These kids evolve into loss of consciousness, and they have serious convulsive movements. So a subtle seizure is seizures that are caused by the immature brain. So therefore we see it more in premature babies than full-term babies. And it's missed a lot of the times. It depends on how the child is presenting, whether it gets picked up or not. Sometimes kids will have, some tonic movement, and at the same time, we'll see that their eyes, are blinking and fluttering. This doesn't last long, seconds to a minute. And generally speaking, it will go away with time on its own. The one issue is sometimes these kids have apnea. So many times parents that take their child home will call and say, I think there's periods where my child stops breathing. And what is done for those kids is they're brought in and a sleep study and an EEG is done. And that's where this subtle neonate seizure is picked up. It depends on how severe it is, whether it's treated. Most little babies will outgrow it. The other one that's a little bit more serious is infantile spasms. And infantile spasms is also called West syndrome. A person named West found them. And we see it at babies. It begins around, or peaks actually, 3 to 7 months old, and usually they outgrow it. We see it more in boys than girls. And it's actually these little tiny seizures. Their eyes generally will roll. We'll see them get a little bit cyanotic. They will have a flexed head, extended arms with their legs drawn up. And it's very brief. It doesn't last long, and it's kind of frightening. Kids do this a lot of times. These babies, suffered anorexia at birth or other issues. It generally go away by, well, this says 18 months, but by age 2, definitely. Sometimes they're treated with a little bit of phenobarb. We worry if it doesn't go away by age 2 that the child will have brain damage. So the test for any seizure is an EEG, and the child has to not have caffeine for several hours, and hopefully the child's not having caffeine. The hair needs to be washed before, but no products are to be put into it. And then when they come back, they will have to have the gel from the EEG leads removed. We have to, if the child's old enough, we can explain that they are going to be exposed to flashes of light and not to be afraid. They usually will hold off, keep the child awake as long as they can so that they'll sleep through the EEG so they don't move. The test doesn't hurt, but the bright lights frighten the children. Sometimes they'll do an MRI, sometimes they'll do a lumbar puncture or CT. They check, make sure they don't have generally any tumors or anything else that could be causing these seizures. And then these labs are also done. During a seizure, I wrote down step by step what's important to do. And the most important thing when a child has a seizure is to provide a patent airway by making sure their clothing isn't constrictive and to turn them on their side. A suction can be there if they're foaming at the mouth, you can use it. But otherwise, you don't put an airway in their mouth and you don't, try to keep their mouth open. Just turning them on their side should do it. If a child is getting real cyanotic, you'll have to administer some oxygen. Be sure that you note what time it started. If you weren't there at the beginning and you walk in it, just jot down the time you walked in, and what characteristics you're seeing, and then what time the seizure ended. Stay with the child, stay with them during the post-ictal stage, and record everything the child says and does. Afterwards, we really try to keep them on the sideline position because they may have a lot of mucus in their throat. When they wake up, we check their vitals and we check their mouth for injuries. We do neurals. If the child is confused, we reoriented them. And we keep their bed in the lowest positions and patting on the side rails. We don't want them to eat or drink immediately because their swallow reflex may not be present yet and they might still have a lot of mucus in their throat. If the child can describe what he saw before, during, and after, it would be a big help for the future. And sometimes you might notice, the parents might notice something that occurred that might have triggered the seizures. I wrote down what most people say, like, it seems like when my child's going through a lot at school, he has seizures, or when he's fatigued, he has seizures. These are the most common medications for seizures that are given. When you watch the movie, you'll hear a lot of these mentioned, and there's status epilepticus is a seizure that lasts longer than 30 minutes or continuous seizure activity in which the client never enters a post-ictal stage. It's a very dangerous thing. Once again, you're going to do just what you would do with any seizure, maintain an airway, give oxygen. But in this situation, many times we want IV access, and they will try to perform an ECG. These are the drugs that are generally given during status epilepticus to calm the child down, to bring him out of a seizure activity. Talk a minute or two about cerebral palsy. Cerebral palsy is a disorder of, actually, I love how this is written, of movement, muscle tone, or posture that is caused by damage that occurs to the immature developing brain, most often before birth. Now, it can also be caused by damage to the brain from a trauma later on. The risk factors include trauma, maternal infection, multiple births, low birth weights, prematurity, interruption of oxygen in utero, or during birth. So here's the assessment of the child when they're young. And this is one of the reasons we try to learn about development milestones. If the child isn't doing it, we actually might eventually start seeing movements that are similar to cerebral palsy. The one thing that in a small child that we see is persistent primitive reflexes. They don't get rid of their Moro or their tonic neck reflexes. And you always check for that in little children when it should be gone in 3 months. So if it's still present, they really should see a neurologist. These kids generally will have feeding difficulties, and they always want to thrust their tongue out. They don't gain head control like other little infants do, and they do abnormal posturing. When they begin to crawl, it's usually asymmetrical. And, a while ago, people were using Berber carpeting a lot, and kids would kind of crawl kind of funky on that because it hurt their knees, it burned their knees. So it was really tough to say if the child's crawl was normal or not. We'd have to have them crawl somewhere else to see. A lot of times these kids have seizures, and they usually have vision, speech, and hearing impairments, and a lot of times hearing impairments is number one. And because, a lot of times they can't speak too well, they have impaired social relationships. They're kind of immature. It's not like they're trying to have an impaired social relationship. They're just immature. So there's 3 kinds, and I loved this little slide that I had from a long time ago. And here they're listed: the spastic, which causes the stiffness and moving difficulties, which is the most common. The athetoid, cerebral palsy, which is involuntary and uncontrolled movements. It almost sometimes look like the kid's twitching. And then the ataxics. It causes a disturbed sense of balance and depth perception. So these children tend to. So again, I wrote them up here, and I put some pictures, kind of, so you could get an idea of what they are, and you can read about them. Remember, the spastic is the most common. So if you would take care of a child that has cerebral palsy, communication may be an issue. Maybe an issue with the patient, because I don't know if you've ever heard one patient speak that has cerebral palsy, but their words are very slow and drawn out, and you have to listen for a long time to get one sentence out. But you still want to communicate with them as if they're talking, where you understand them. You also want to communicate while the child's in the hospital to the families and all the procedures being done. You want to include the family in taking care of the child because they've been taking care of him at home. And you want to find out the home routine so when the parents leave for a while, you can continue on with it. We generally keep their head of the bed elevated to keep their airway open. These kids tend to have a lot of secretions, and they can aspirate very, very easily. Suctions at the bedside. And if they're in for some procedure, they can't tell you if they have pain. You're going to have to use the Flex scale and monitor for pain. Many times these kids come in for like tendon releases. There's special ways to feed a child with cerebral palsy, and if the parent's there, they can show you. If they're little, you're going to have to hold them upright and small, frequent breaks during that feeding. They're not going to suck the way a normal newborn sucks. If they're bigger, you're going to have to feed them, but be careful. These kids tend to aspirate often. Skincare is important. You know, if they're not walking much, they're sitting down a lot, so their bottom is going to get broken down if they're in bed. And most of them wear some kinds of braces and orthotics. So, you know, every couple hours you need to remove them and massage it with lotion and check for redness and pressure sores. They tire out because every time they walk, they're exhausted. When you watch them walk, you'll be exhausted watching them. So they need rest periods. The parents need a lot of support, and it's important, especially if it's a new child, a new diagnosis, to provide the community resource list for them, support groups, respite groups, so that they can take a break. A respite house is where they have an appointment to take the child and drop them off, kind of like a babysitter, but only with people that know how to take care of them so that they can get away from them for a while. And a lot of these things are really important if the child develops cerebral palsy secondary to a trauma later on, because this is a whole new world for those parents. Monitor for impaired hearing. Although all three senses are usually affected, definitely speech, impaired hearing is one of the hardest ones to determine with these kids. So your education is listed here. You know, important things like dental checkups, developmental stimulation. Don't just let them sit there and watch TV all the time. If they have sores or wounds, how to take care of them and how to take care of the braces. Many of these kids will need to be straight cath, and you may have to be the one to instruct the family on how to do it. A lot of them develop aspiration pneumonia, so they need to learn pulmonary hygiene techniques that they can do at home. And they need the numbers to support groups and respite houses. Here's the medications, and the first two are basically skeletal and muscle relaxants that decrease muscle spasms. The first one, baclofen, is given to almost every cerebral palsy child that I know, and it can be given oral, or they have a pump and they can do it intrathecally. And it really works well for painful muscle spasms. That's one of the reasons they tend to do the tendon releases, is the pain is so bad. It probably isn't going to help them walk any better or do anything better, but the pain is so bad. The diazepam, once again, is also used for the same thing. The botulism, you know, the other, botulinum, the other name for this is Botox. And they use that when specific muscle groups are really, really tight and spasming. They'll use this, and the onset for it to begin working is around 24 hours or so, and then it'll peak at 2 months and stay at that level. It'll peak at 2 weeks and stay at that level up to 6 months. Many times these kids also have seizures, so they'll need seizure medication. Hydrocephalus is another neurological problem we see in children. It can be congenital, where they're born with hydrocephaly, or it could be acquired, where they maybe they're in a car accident or have a trauma later on that causes the fluid buildup in the ventricles. So what we'll see with a little child with hydrocephaly is definitely bulging fontanelles. And we say split sutures. Their fontanelles are so far apart, it looks like their sutures are split, and you can see them. They also will have these prominent scalp veins that you don't see on other babies. When you measure their head, you'll see an increase in head circumference. Their eyes will be at a sunset level. They'll have a high-pitched, irritable cry. They're generally poor feeders. And if it's an older child that hadn't been diagnosed, like maybe from a trauma, they'll complain of constant headaches. This picture I love because it talks about the cracked pot sound on percussion. If you percuss on their skull, it sounds like a cracked pot. Pretty interesting. Look at this picture and try to remember it. These are really typical signs of hydrocephaly. what they usually do for these kids, they need to get the fluid off of the brain or between the ventricles, or they'll become severely mentally retarded. Some have cognitive issues and some don't. And the same thing with cerebral palsy. Some have cognitive issues and some don't. So just because they can't talk to you, don't assume they have cognitive issues. So they put this little shunt in from the ventricles, usually all the way down to the abdomen. It's a ventricle peritoneal shunt. There is a second one I'm not as familiar with, and I don't know that it's done that often, but they take the shunt and put it in the ventricles and it routes somewhere else. I think it might route to the heart, but it's not done that often. Okay. So you want to assess for signs of increased intracranial pressure postoperatively, and when you take care of them in the hospital. They'll have medications, some steroids and antibiotics. Shunt care, there'll be a little incision on their head, and there'll be a little incision on their tummy initially. So you'll get an order for whatever the physician wants for shunt care. When these kids come back from surgery, they usually have their VP shunt hooked up to a manometer, and this measures the pressure. So the kid will come back from surgery and he will be at usually, like a 10 or 20 degree angle in the bed. The doctor usually will slowly let you elevate the bed, but they want to keep an eye on the increased intracranial pressure. And actually, it's the opposite. So when their head is elevated, the pressure might drop too low, and the child could herniate his brain. So it'll be a very slow raising the bed. It takes several days to weeks before the child can actually sit up. You'll watch for signs of shunt infection and malfunction, which would be changes in their neural status, vomiting. There'll be redness at the shunt track. And when a child has one of these, you actually can feel it. And sometimes if it's a thin child, you can actually see it under the skin. You'll teach the parents the signs and symptoms as well for shunt infection and malfunction. So here are the symptoms of shunt malfunction or an infection. Headaches would be an older child that could tell you. The baby will be very irritable with that high-pitched cry again. Vomiting, definitely. Whenever a child that has a VP shunt is vomiting, we check out that their shunt is working correctly. We don't assume it's always the flu. Again, swelling or redness around the shunt track. Periods of confusion, seizures, sometimes a fever. And if it's an older child, sometimes they're having a hard time concentrating at school. Shaken baby syndrome is another neural issue that we see. The baby is shaken, and this picture shows you just what happens to their brain. Unfortunately, usually they'll come in because they won't eat or they're vomiting when they eat. And we usually can't see much, but there'll be a pale blue skin around the forehead, and they'll have what we call lethargic eyes, like they don't want to keep their eyes open. We watch for signs of increased intracranial pressure and signs of shaken baby because they're very close, and the child may have both. But the signs of increased intracranial pressure in general are on the left. The signs of shaken baby syndrome are on the right. It usually encompasses the increased intracranial pressure and adds to it with the breathing difficulties, the paler bluish skin, the retinal hemorrhage, difficulty staying awake. So you need to know the signs of shaken baby, but remember, increased intracranial pressure is also seen at the same time. So generally the actual diagnosis is made when they do an ophthalmological exam and they see the retinal hemorrhage. So the top picture is a normal retina, and the bottom picture is a retinal hemorrhage. Remember, the risk factors is interesting. We see it in this more in young parents or young people taking care of the baby, premature babies, unstable families. It's seen, although it occurs in any social economical group, we see it more in the low social economical group. We see it with child care providers that really don't understand how to take care of a baby and understand the development of the baby. Unfortunately, treatment is supportive at this point. If the baby has a retinal hemorrhage, sometimes, a lot of times, they go into a coma and don't wake up. However, if it's a mild chicken baby syndrome, we need to work on prevention and educate these parents. So some things we can do is assist them with methods of consoling their crying baby. Show them ways that, comfort the baby. Teach them about coping skills. They need to take parenting classes. And that this baby really needs a social service follow-up if they get to go home with the parents. Sometimes they go to a foster family if they're not in too bad shape until the parents have completed parenting classes.